Hi everyone. In this brief lesson, we will talk about incontinent urinary diversions, or as you may more commonly have called them, urostomies. Like fecal stomas, urinary diversions are surgically created using components of the bowel and incorporate parts of different urinary anatomy depending on anatomically where the diversion will be constructed. The decision on what type of urinary diversion will be constructed depends greatly on the specific disease process involved, the general physical condition of the patient, and a discussion between the urologist creating the diversion and the patient where disease process and options are explored. The purpose of any urinary stoma is to divert the urinary stream. They function immediately upon creation. Usually these are permanent, but in some cases they can be temporary. Urinary diversions are most commonly done for bladder cancer, 90% of which are urothelial cell cancers. Now, urothelial cell cancer is a newer terminology and replaces the previous term, which was transitional cell cancer. Inflammatory conditions that can result in a urostomy include radiation cystitis and interstitial cystitis. In both conditions, individuals may experience frequency and urgency of urination, burning and pain, as well as gross hematuria, the extent of which varies based on the amount of inflammation within the bladder. The exact cause of interstitial cystitis is unknown and occurs most commonly in women. It is thought to result from a disruption of the epithelial lining of the bladder, autoimmune reactions, hereditary factors, or infections. Less common causes for urostomies include neurogenic bladder and congenital malformations such as bladder exstrophy and posterior urethral valves. A cystectomy, or removal of the bladder, or cystoprostatectomy, which is removal of the bladder and the prostate gland, is necessary for treatment of bladder cancer. In some situations, the bladder can remain in place. Preoperatively, surgeons should thoroughly discuss with the patient the varying types of urinary diversions possible, and a joint decision is made as to the best option for a particular person. If the patient opts for an orthotopic neobladder, for example, and starts to decompensate on the surgical table, conversion to an ileal conduit may need to occur. This discussion and all potential complications are communicated to the patient by the surgeon as part of the informed consent process prior to the planned surgery. When an ileal conduit, catheterizable stoma, or orthotopic neobladder are planned, stoma marking will occur preoperatively. Urinary diversions that are rarely done include vesicostomy, ureterostomy, and sigmoid and jejunal conduits. The more common diversions include nephrostomies, which are seen on the abdomen with a tube and drain, ileal conduits, continent urinary diversions, which are the historical cock pouch, and the more current Indiana pouch, and the orthotopic neobladder, which is also called an orthotopic bladder substitute or orthotopic urinary diversion. We will delay discussion on the continent diversions until later in the course. For now, let's just focus on the incontinent urinary stomas. Let's start with nephrostomy tube. A nephrostomy is a urinary diversion procedure that occurs in conjunction with radiology. The tube is inserted with radiology guidance directly into the kidney, into the renal pelvis. Urine is collected from the renal pelvis and diverted out of the kidney via a percutaneous tube and into an external collection bag. In the case study photo on this slide, you see an example of a nephrostomy tube with a vinyl disc sutured to the skin. This is intended for use as a stabilizing device for this nephrostomy tube. In the case study, you can see where leakage occurred around the tube, which led to candidiasis infection of the skin around the tube insertion site. In most instances, peritube leakage can be prevented through the use of good tube stabilization options. One particular problem many patients ask about is the tube adapters that connect the nephrostomy tube to the leg bag that collects and contains diverted urine. The patients may call and ask specifically about the adapters for the leg bag and drainage bag. Now, generally these are stored or given out in radiology directly after the procedure, where these devices are placed. So you may want to consider having a supply of these in your office product formulary. Now let's move on to vesicostomy and ureterostomy. Now, vesicostomies are most usually done for children. If the child is in an age where diapering is acceptable, this is a good way to manage this type of opening. It is important to use some type of a skin protection product, such as a non-water soluble sealant or a petrolatum-based product. Pouching can be attempted, but it could be very difficult to obtain a predictable and reliable seal. Ureterostomies were more commonly done in the past. The ureters were generally sutured on separate parts of the abdomen as seen on the photo on the right-hand side of this slide. They can also be brought out next to each other, but this can be difficult to do from a surgical perspective. Nowadays, this is done as an emergency type of procedure. The stomas are very tiny, generally less than 7/8 of an inch in diameter. They will grow into the aperture size of the pouching system, so correct fitting is extremely important. They are also freely refluxing, so there's a danger of increased urinary tract infection, hydronephrosis, and hydronephritis. The most common incontinent urinary diversion is the ileal conduit. In this surgery, a 12 to 18 centimeter segment of ileum with the mesentery intact and attached is isolated from the rest of the ileum. The two ends of the remaining ileum are then anastomosed or reconnected to restore the gastrointestinal continuity. The proximal end of the isolated ileal segment is sutured closed, and then the distal end is brought out onto the abdomen and a stoma is created. Then the distal ureter ends are sutured into the isolated ileal segment as seen on the center photo on this slide. The ureters are anastomosed to the segment in a way to have the urine flow out of the stoma and into an abdominal collection device or pouching system. Even though the ureters are brought out under the ileal segment for attachment, again, as you can see on the center photo on this slide, urine can still freely reflux back into the kidney because there's no specific anti-reflux valve. The right lower quadrant is the usual location to site preoperatively for an ileal conduit. Again, external stents are most generally placed during surgery and can be seen in this photo. Ileal conduits will function immediately and continuously with urine. The urine does not irritate the skin the same way a fecal stoma does. Urine can, however, cause overhydration of the peristomal skin. This is a condition called pseudoverrucous lesions and closely resembles skin that has been exposed to water for too long a period of time, similarly as when washing dishes or dishpan hands. We will discuss this in more detail in the lesson on peristomal skin conditions. Now, because of the risk for urine refluxing back up to the kidney, urinary tract infections are common. Use of a constant nighttime drainage system, such as a bedside Foley urine collection bag, is recommended during sleep, so the person does not have to get up in the middle of the night to empty the pouch, and this also prevents the pouch from becoming too full and pulling away from the abdomen, again in the middle of the night when the person's sleeping. Another option would be the sigmoid or jejunal conduit. These types of conduits tend to only be used if there is ileal disease, such as would be found in Crohn's disease or radiation damage to the ileum. Jejunal conduits lead to electrolyte disturbances that are characterized by hyponatremia, hypochloremia, hyperkalemia, acidosis, and azotemia. Clinically, these individuals present with nausea, vomiting, dehydration, anorexia, lethargy, and muscle weakness. This can be treated with salt and bicarbonate repletion and hydration. Another option is the ureterosigmoidostomy. With this surgery, the ureters are implanted into intact sigmoid colon. Stool and urine are evacuated through the anus, and continence is maintained by the anal sphincters. Just as the case with jejunal and sigmoid conduits, complications can include metabolic abnormalities, such as reabsorption of chloride and the excretion of bicarbonate and sodium. So electrolyte complications, of course, would need to be monitored very carefully for this person. And nursing education would need to include signs and symptoms of these problems. Other potential complications would include ureteral obstruction, incontinence for those with poor anal sphincter function, urinary tract infections, particularly pyelonephritis, and an increased malignancy risk, sometimes as high as 40%, as seen in some reports, within 7 to 49 years after surgery. As you can imagine, this is a procedure that's rarely. Stents are used in both continent and conventional urinary diversions. Stents, one for each kidney, are normal and serve as splints for the ureteral ileal junction, as well as a pathway for urine to exit the kidney in case of edema would occlude the uretero-ileal anastomosis. The stents remain in place for about 4 weeks and are easily removed. Each stent's protruding end is cut differently. The stent that is in the right kidney is cut straight across, and this is also called a right angle to help you remember. The stent in the left kidney then would be cut to an oblique angle. When they're removed, they usually come out one at a time in order to determine which side is affected if there's a problem with urinary function after stent removal occurs. For example, if the right stent is removed and a significant decrease in urinary output is noted over the next 2 hours, one could surmise that there's a difficult issue or difficulty with the right side. Finally, all patients with any type of urinary diversion need to know the signs and symptoms of urinary tract infection. Symptoms the individual may have been familiar with before surgery can no longer be relied upon. So with a urinary diversion, signs and symptoms of a urinary tract infection would change then to a change in the odor or color of the urine, an increase in mucus shreds, flank pain, and fever. These are all signs that could indicate the presence of urinary tract infection. Adequate fluid intake, the use of constant drainage at nighttime for those with a conventional or incontinent stoma, and keeping the urine at a slightly acidic pH are measures to help prevent urinary tract infection. Individuals may find vitamin C or cranberry tablets helpful in maintaining an acidic pH. Individuals on Coumadin or warfarin, however, should avoid cranberry products. This concludes the lesson on incontinent urinary diversions. The nursing care involved will be discussed in the upcoming week's discussion questions. The chapters listed on this slide can provide more detailed information if you have an interest in exploring this further. Thank you for your attention.